Good morning and welcome to Beyond Telehealth. And telemedicine is medicine. I'm Dr. Lisa Finkelstein and I will be your host. And this is exciting today because I have another true telemedicine fan and champion, Chad. I'm going to say it, Ellimoottil.
You got it. You got it.
So Chad, introduce yourself. Tell us what specialty you practice, where you practice, what EHR you guys use, and what telemedicine platform that you use.
Sure. So I'm an assistant professor of urology at the University of Michigan. So I've been there since about 2016. And we've been actually, at least personally, I've been using telehealth since about that time. Currently, our health system is using the Epic platform for our electronic medical record. And then also we use it's our telehealth app platform is integrated through Epic. And it's actually on the back end, we're using Zoom. But it's all through the patient portal over there.
Wait, so you use Zoom in addition to what's embedded in Epic? Explain that a little.
Yeah, so Epic has a app market, and essentially there's a number of telemedicine providers platforms that are part of that market. So the one that we chose is Zoom. So what happens is that the patients log in through the portal, through their own patient portal. And then when they click on the visit, it's actually their Zoom app that opens up and on the back end, and that's how we actually connect. So from our experience standpoint, from the patient's experience standpoint, the entry point's a little bit different, but once you're in the visit, it's identical to a Zoom conference. So including the screen share and so forth.
Yeah, I didn't know that Epic could partner with Zoom or anything.
Yeah.
Okay.
Yeah, they do. They partner with. So we had prior to the Zoom platform, we were using a different platform called Video, and then I know Amwell is integrated with Epic too. So there's a number of platforms that are integrated within Epic.
Right. Okay. Can you give a quick summary of this wonderful collaborative team that you work with, the Telehealth Research Incubator at U of M?
Yeah, certainly. Yeah. So within U of M, there's the Institute for Healthcare Policy and Innovation, which is essentially a large collaborative from multiple different schools across campus and people that are interested in studying health services research or the delivery of healthcare. And so within that institute, I run what's called the Telehealth Research Incubator. And the Telehealth Research Incubator started at, I think it was around 2018. And the idea behind the incubator was that throughout the institution, there are a lot of people that are interested in telehealth research. Let's kind of bring people together. Let's accelerate the research. And that's how the incubator started. And essentially what we do is we study the population level impact of telehealth on costs, on access, on quality, and also the patient experience. So rather than being focused on developing software or running clinical trials, we look at the population level impact, which was pretty low up until March 2020, but now has actually been booming for sure.
Right. As we say, timing is everything. And before pre-COVID, when I would try to get people interested, they'd say, what is this? And I would say telemedicine is medicine. And now I say, thank God for the pandemic.
Yeah.
Without that, we would still be pushing the rock up the Grand Teton.
Yeah, I totally agree. Actually, I used to give a lot of talks prior to the pandemic. And one of my go-to slides was this graph, which essentially said telehealth is going to be one of the most important changes in healthcare in the future. And I would keep showing that graph. But right afterwards, I would have to sort of, I would explain what it is, and people will say, well, that makes a lot of sense. And then I'd have to go through and explain the 20, 30 slides on the regulations that hold it back. And they're like, okay, we're a little less interested now. So
I talk to the hand, Lisa, talk to me in the future. That's what I got all the time.
Right. Yeah.
This is the perfect segue. So the next thing that I would say is the future is now. But
yeah,
the previous interviews are talking to physicians, and I've learned so much, talking to nurses and physicians about the struggles and how everything has gone. But Let's dream big. You and I are telemedicine champions. We understand it. We get it. We know that this can help patients with access and care. What are your thoughts about what this could look like in 5 years, 10 years, 20 years? You're going to still be practicing urology in 20 years. Let's break it down. What's the future look like in a dream?
In a dream, yeah. So I, well, I think there's a lot of reasons why the dream could become a reality too. I mean, it seems like things are moving in that direction. So, one way to think about it, or a framework to think about, is the hype cycle. And so I don't know if you've heard of that before, but it's basically a model that's used to think about the evolution of technology. So initially, there's some sort of innovation trigger, something that gets the technology going. Then there's this big slope of heightened, unrealistic expectations, and then there's this trough of reality, and then you get into this slope of enlightenment. And I think that's what we're going through right now. Initially, while telehealth technology has been around for a long time, really the trigger for the innovation and the widespread adoption was COVID-19. And so then we reached a phase where we see that as in-person care is becoming safer, some of the regulations are inevitably going to come back after the public health emergency. I think that we're going to end up in this sort of trough where patients will probably prefer to come in person, and then the regulations will make it burdensome for providers to provide telehealth. So we'll be in this trough eventually. We can see when we look at national data that the numbers are starting to drop, and the vast majority of care that's delivered now is through in-person care, as opposed to how it was in March, April, and May of 2020. And so we'll reach this trough, but then eventually, and this is kind of the long-term vision, is that we reach this peak, this slope of enlightenment where telehealth is being used in a clinically appropriate way. And just like you mentioned earlier, it's really just integrated into care. And I think that's my long-term vision, that it's not actually separate. And I don't think from a policy standpoint, from a payment standpoint, from a regulation standpoint, it really should be treated that way. It's an extension of care. And I think as healthcare providers, we can make that decision of when it's appropriate clinical care, when it's guideline-based. Eventually our organizations, professional organizations, will develop guidelines for this, and when it should be used. And when it's used as an extension of care, I think there's a lot of good things that'll come with it. One, it'll be a substitute for care, as opposed to this business model of increasing your revenue and so forth. It's really just a substitute for care. And then number two is that we sort of decide when it's the safest to use it. And then number three is we sort of decide on what the limitations are. And once it's integrated, I think that once it's integrated that way, I think that we'll probably end up about 20% of care being delivered through telehealth. And I think that number will slowly, over the course of 5-10 years, probably increase as we gain even more ability to sort of find out what's clinically appropriate, and we get enough more experience with this. But I don't think it'll eventually overtake care or the amount of in-person care that we're doing, but I think it should at least be a substantial amount of care. I think that incremental increase that we see over the next 5 to 10 years will really be for people that have difficulties with access now. So people will become more familiar with the technology now. And so when they defer a video visit because they can't use the technology, that population will become smaller, and people that are familiar would become bigger. And then also as federal policies change and there's broadband in rural areas, then more people will have access to this type of technology. So that will cause the incremental increase in the use of telehealth over the next 5 to 10 years. And I think ultimately we should be moving towards healthcare in general should be moving towards a model which will probably not be realized for another 5 to 10 years of virtual first, which means that you come to a physician's office or a healthcare provider's office when you need a physical exam or you need a diagnostic test done. And if you don't need either of those, then there may not be a need to come into the office, and it can be done virtually. The exception would be, I think there's a lot of people that will say even now that they feel like they get greater rapport by meeting a person in person. And so, that could be the exception if you want to come in for the first appointment, if you want to come in, if you need to, for a physical exam or for a diagnostic test. And that's the true spirit of a virtual first model, which I think will ultimately, over the next 5 to 10 years, be the primary model of care delivery.
I love that, virtual first. I use the term virtual house call.
Mm-hmm.
Yeah. What about, though, the concept of having care from the home? I know in Wyoming, where it's very, very rural, that the legislature talks about aging in the home. And so let's use that dream again to empowering patients using devices at home, and then the data is transmitted. Talk about that dream.
Yeah. So essentially being able to be managed at home, and then really only needing to come in if there's some sort of alert that's created in the data that's being collected. I think that that's certainly a dream, and it seems like we're pretty far from that, but probably closer for some conditions than others. I mean, for urologic conditions that I treat, perhaps not a lot of innovation in that area for monitoring patients at home, but certainly for congestive heart failure, for patients with COPD, for patients that need diabetes management, that seems like what would probably be the primary mode of management, where they're at home, they have a device that collects the information that that the clinician that's following them needs to make decisions on them. And then again, only coming in to see that particular clinician if it's absolutely necessary.
How do you think that some of these, mega players like Amazon and
Mm-hmm.
Google and, these technology-driven organizations are going to penetrate this virtual first market?
Oh yeah, they will completely disrupt this market, because if you think about, I mean, it's simply based on the fact that they have a different kind of cultural perspective than many healthcare organizations. And for better or worse, as much as I think a lot of healthcare organizations talk about, patient-centered care, in a lot of ways, the care is actually built provider-centered. It's really easy for a provider to go from door to door in their clinic, from clinic room to clinic room, and see patients, and not really knowing the backstory of how long it took them to get there. And that's how care is ultimately centered, and that's actually how care is reimbursed too in this country. Right. So that's how the healthcare system is set up. And if you look at the mindset of companies like Amazon and Google and so forth, they've always kind of had a obsession with the customer. I think Jeff Bezos, that was one of his quotes, was that we've become so successful because we obsess over the consumer, and they try to make the experience for them better. And that's why it's so easy to do a return on Amazon, and that's why it's so easy to do a lot of purchases, get reviews. All those are things that consumers want, and those are things that patients want too. And
right.
When they bring those types of lessons that they've learned from the retail market to healthcare, I think it's going to certainly disrupt sections of healthcare. They're still going to be limited in certain types of specialty care, procedures, and surgeries and so forth. But I think for basic care needs, it'll certainly become a big proportion of care delivered.
I have to say that I'm on the downslope of my career. An older physician, it took me a while to get this consumer model. The hospital is so worried about patients' satisfaction and surveys and things like that. But telemedicine, I could see the light when I started to really get into telemedicine.
Yeah.
And I really do think that doctors, we feel demeaned by this concept, that we're just another sort of cog in the machine. But I do think that it is going to disrupt things in a huge way. And the younger doctors kind of get it.
Yeah.
Although, they're also a little angry about it. But I just think it's inevitable that these disruptors are gonna penetrate the virtual first concept.
Yeah, I think ultimately, most healthcare providers just want to, provide the best clinical care and best experience for patients. The problem is that often, like, we want to do it, but then often that conflicts with regulations, and also conflicts with reimbursement models. Like, if
Yeah.
if a patient has a quick question or just has a few things to talk about, it's easy to send a portal message if they want you to review a paper that they saw and wanted to actually, or review an article that they read and they want you to give your thoughts on it. It makes a lot of sense to just send a message to us, and then we could write out a response. But the problem is, if you spend 30 minutes of time reviewing that article and writing a thoughtful response, that that they're going to, everything has to be accurate, because they're going to be taking that to heart, because it's coming from you. So if you're taking the time to write that, you're not necessarily reimbursed for that type of effort in our current system. And so there's a direct conflict between what we want to do and then how the healthcare system is structured.
Right.
That's going to take a lot of change, and there's a lot of inertia to that change, deliberate and unintentional, but also a lot of purposeful reason why the system is that way. Telehealth is certainly a step forward, but it's just a matter of aligning the provider experience and also the patient experience to kind of maximize the experience for both.
Yeah. Yeah, it's an interesting time. So let me go to your research.
Sure.
So your research is focused on the optimization of virtual care, which we were talking about. What have you learned that will promote the best way to deliver this type of care? And do you think that telehealth will improve health?
Yeah, I think that telehealth has the potential to improve health, and there's 4 areas that my group studies the delivery of telehealth and focuses on the optimization of telehealth. And that first area is healthcare access. The second area is healthcare spending, which is important for national policies, healthcare quality, and then also the patient experience. And if you think about each one of these pillars, there's an opportunity for telehealth to improve health. I'll give you a couple examples. Let's just talk about healthcare access. So with healthcare access, there's unlimited numbers of studies that have shown that healthcare access improves outcomes. And it's whether it results in being diagnosed with a disease earlier so that you can get curative treatment, or just having symptom management so you don't have to go to the emergency room. There's countless studies that have shown that healthcare access improves outcomes. But the relationship between telehealth and healthcare access is not straightforward. So healthcare access is not monolithic. Healthcare access includes, in epidemiology, there's like the 5 A's of access. So it has to be accessible, it has to be available, it has to be affordable, and so forth. And so telehealth is right before this. So it has the potential to improve healthcare access, but it has to meet all those criteria for healthcare access. So if you are providing telehealth as a healthcare provider, but that telehealth is inaccessible because of financial constraints or broadband constraints to the people that need it the most. So you look at where populations have disparities, like rural populations, racial ethnic minority populations.
Yeah, urban for sure.
Yeah, and so if you look at those populations that need it, is the telehealth actually reaching those populations? We did a recent study where we used the COVID-19 as a natural experiment, and we looked at how during that time period our health system was ready to go with video, so video consultation. So we were looking to convert all of our appointments, especially in March, April, May, to video. And so we looked at that. So patients had a choice of, they could come in person if they needed the care, they could defer care if it was urgent. They could do a video consultation, or they could do a phone consultation. All those are options. And we looked at the populations of people that chose each one of those options. And it was pretty clear. The association with age was very strong. In 10-year intervals, you saw that the use of phone dominated over video use. Minorities need an interpreter, Medicaid. These were the things that stood out the most. And on top of that, most of our patients didn't just have one factor. They actually had a number of factors.
Many, right.
That led to their reduced chances of using video. And so as a result, what we see is that, at the national policy level, if you take away phone calls and don't allow that or don't reimburse it for telehealth, then that becomes a loss of access for patients. And that could be one way that telehealth can reduce healthcare access. And
Right.
yeah.
Well, I think one of the things that happened was Medicare, CMS has always struggled with access for, trying to figure that out. And that's why for the past couple of years, going back to 2018, they were dipping their toes into coding for telemedicine and using the rural, model, originating site, distance site. And that's what I did. I spent, 3 years getting originating sites set up in rural Wyoming.
Mm-hmm.
And then when the hit the fan, and Medicare did have these things in place for telemedicine to help with access. But now they really see, so this was also, I was thinking maybe you would say this in your dream, is that fiber would be everywhere.
Yeah.
Right? We would have reliable internet everywhere. That in the United States of America, we should have that capability. That's a dream.
Yeah.
That every little nook and cranny in Wyoming, up the mountain, down the canyon, could have that.
Yep.
The other part that I think the myth was that older people that didn't understand how to download an app and use a video and things like that, they were actually more prone to wanting to learn how to do a video visit. One of the physicians told me a story of their 93-year-old patient who couldn't figure it out and went to Verizon store and said, I want to see my physician. Can you help me, figure out this video visit? Yeah. So, the myth was that an 80-year-old didn't want to do a video visit, and we find that that's not necessarily true.
I totally agree with that. I think older patients tend to be more devoted to their appointments too. And there's an obvious difference where when we looked at no-show rates and completion rates, we actually found that they were parallel to in-person care. And so you have the older patient who would show up for the video visit. They're dressed nicely. They have a piece of artwork in the background, and the visit goes perfect. And then you have younger people that kind of assume that they're driving. Yeah, they're driving. They assume that they know how to do it, so they may not download all the pieces that they need, and then it ends up being a no-show. That's what I see that anecdotally happen a lot, and I agree. There's I think that older patients certainly go to extra effort to make sure that they can try to do it. And I think for that reason, and especially since they're the ones that need the most care, I think making it as easy for them as possible is just to be a very high priority.
Yeah. So one of my passions is teaching telemedicine. And so what are some of your ideas in regards to trying to get telemedicine in the curriculum for medical students and nursing and pharmacists and PT and speech and all these professionals?
Yeah, I think, in order to get there, I think, in order to train providers in general and become familiar with it, I think it needs to be built formally into the curriculum. And so, how do we learn how to do a heart and lung exam? We have standardized patients. And so I think that the same principles that we use to teach the important elements of in-person care should be, taken so that we could, teach how to do video visits. And I think doing a video consultation is different than in-person care. There's nuances. There's this concept of website manner, a website etiquette, and there's things that are different. One simple thing is that you have to kind of stay focused on the camera. So when you're in a room, there's that famous piece on the cover of JAMA about it was a little girl's description or picture of what she drew when she was at the doctor's appointment with her parent. And it was a picture of the doctor sitting in front of the computer, just typing. And so, that's familiar for a lot of us. But if you're in a room with a patient, they know that you're sitting there typing, you're looking through their records and looking through their images and so forth. When you're not in a room with them, they think you're just looking away or distracted. And, it's probably not true. You're probably focusing on their need, but it can give that perception, and it could impact the experience. So those types of things, I think, need to get formally taught through a curriculum. And actually, at University of Michigan, we've had a lot of folks that have, raised their hand to help develop these curriculum. There were a lot of medical students that have shadowed with me, for example, and have taken notes in terms of, steps for conducting visits. One of our residents, Juan Andino, put together a curriculum with some of the medical students that is being pitched to the medical school. So I think that there's a lot of excitement for this, especially the younger generation of learners realize the potential of this because they were brought up in the digital world. So I think there's momentum, and I think we're going to see a lot of formal curriculum changes. That goes not just for medical school, but also nursing school and PT school. Yeah,
right. Because we also have these peripherals now that can be out, in the field or in the clinics or in the nursing home, where they can use the otoscopes and telestethoscopes and things like that. And the preceptor could be in their office and not necessarily, they could be on the cow.
Yeah.
And watching, with the students real time.
Yeah, definitely.
Yeah, I think this is another part of the dream that I have.
Yeah.
Is to be able to do that.
All we really needed was just people to acknowledge this is a way to, and, for better or worse, that happened with COVID-19. So I think that it's enough. It's in the language now. It's like in the, people understand it. Most people know what telehealth is now. And so it's, I think that was enough to just get all the innovators in our country to sort of, start to build curriculums, build standard practices and all that. And I think that's why I think that, the reality or the dream in 5 to 10 years will certainly be a reality more so than a dream at this point.
Yeah. Well, let's leave with the last quote. I'm going to read it because I stole this from one of your talks that you love. So technology is capable of doing things, but it doesn't want to do great things. It doesn't want anything. And this was spoken by Tim Cook, the Apple CEO.
Yeah.
Why do you love this quote?
Oh, actually, the last line of that quote is really important, which is, it doesn't want to do great things. That part takes all of us. And
that part takes all of us.
Yeah, exactly. So I think that it really embodies like what my guiding principle with telehealth and why I do optimization research for telehealth, because it's not the technology itself. The technology is very simple. You and I are communicating through just a video connection. That's it. It's really how you use it, when the clinical context that you use it, how you maximize the experience, use the functions in the program to improve the care experience for patients. When you use it, how you react to when there's an issue. Those are the real things that are going to drive quality and honestly, and drive costs and drive access to care. And I think that those elements need to be real. We need to study them. Researchers, clinicians need to understand it, do QI projects. Medical students, we need to teach it in schools. And once we do all that, we can really do great things with this technology. But the technology itself is not going to do the great things.
Well, Apple was always about the why, and that was, and that's really was always my trying to get physicians to understand the why of telemedicine, not focusing on the technology. I think, the pandemic lasted longer than 3 months, which was long enough for them to start understanding the why of access, efficiency and all those things that we know telemedicine can do.
Yes, absolutely.
Yeah. Well, I'm going to end here, and but hang on for a minute. I'm going to end the broadcast, but just hang on. Okay. Thanks, Chad. I really appreciate it. It was great talking with you.
Yeah, thanks, Lisa, and thanks for having me on.
Okay. See ya.